let's cover the cholinergic agonists first. So we will go with the examples, the uses, and the toxicities or adverse effects of these drugs. First, we should remember that there are two main divisions of cholinergic agonists by mechanism, the direct acting ones and the indirect acting ones, which are also called cholinesterase inhibitors. For the direct acting ones, our most commonly mentioned examples are pilocarpine and the choline esters. So we have multiple choline esters. For the cholinesterase inhibitors, we have edrophonium, the stigmines, and the organophosphates. So under the plural words, we have many examples. So let me lay them down already. And then another special note is that under the cholinesterase inhibitors, we have a dedicated group of drugs that don't have a common structure but have a common target, which is Alzheimer's disease, which include the following. So now let's go to the individual examples and let's see what their effects or uses are. First, starting with pilocarpine under the direct agonists. It's one of the older known cholinergic agonists. It's been out there for decades, and it's almost always administered as eye drops for glaucoma, which is a disease or a condition wherein the eye has disturbances because of increased pressure inside it or intraocular pressure. Now, there are some cases of glaucoma wherein the reason for this is the build-up and the trapping of aqueous humor, and it doesn't go out for some reason as tears. So by giving pilocarpine, and it's an agonist, it will stimulate M3 receptors and cause this to go out, therefore reducing the pressure. This is the mechanism that is found for a good majority of cholinergic drugs that also treat glaucoma, because there will be a multitude of others to be mentioned later. For the choline esters, we have methacholine, carbachol, and bethanicol, which are all modified versions of acetylcholine, and they have different uses. Methacholine, for example, is not so much used as a drug, but rather as a diagnostic aid for asthma. So the context here is, let's say we have a patient and we're not yet sure if he or she really has asthma, because everyone sneezes, but how about, or has difficulty breathing, but how about him or her? What you can do is to administer some of these, and if the patient gets triggered very easily based on the judgment of the clinician, then that may confirm asthma, may or may not confirm, that is. Now, carbachol is another drug used for glaucoma, so similar mechanism, whereas bethanicol is used to induce urination. Usually, the context of inducing urination with this one is cases wherein patients have undergone a surgical operation and they still cannot urinate even if it is already needed for them to urinate. So you can administer this, stimulate M3 receptors in the bladder, allow it to contract, boom, you have urination. Okay. Now, for the indirect acting ones, we go first to edrophonium. And this is usually the first cholinergic agonist mentioned in books, for the reason that it is the shortest acting among these examples. So we can properly call this a short-acting cholinesterase inhibitor. And really, its most commonly mentioned use is for the diagnosis of a condition called Myasthenia Gravis, or MG. So in Myasthenia Gravis, the problem is that the NM receptors, which are usually the receptors that you need to activate to contract the muscle, are being attacked by their own body. So if that happens, then the control over the muscles will go down and people find themselves unable to freely move around their arms, hands, legs, even, for example, parts of their face like the eyes, which is comprised of a lot of muscles. Okay. And so by giving a cholinesterase inhibitor, blocking this enzyme, you increase acetylcholine, which might offset the problem here. Okay. However, edrophonium can only be used for diagnosis, but not treatment, because it's way too short acting to sustain effects. So in that case, we need to recognize that stigmines are longer acting than edrophonium, though we call them properly as intermediate acting because the organophosphates are even longer acting. So these are the ones which actually gain the title long acting cholinesterase inhibitors. And this time, at least, stigmines act longer than edrophonium. This is the treatment for myasthenia gravis. Also, it's well known and applied that these different stigmines, physo, pyrido, and neostigmine, this is usually the classic trio of stigmines, or sometimes we even call them as carbamates, structurally speaking. So don't be surprised if in your references, stigmines are called carbamates. It's this is the suffix and this is the chemical component common to them. These are also used for glaucoma. This is not supposed to be surprising at this point. And also, we can use stigmines to treat excess or toxicity due to neuromuscular blockers. So sometimes neuromuscular blockers, which are supposed to relax a patient's muscles in the context of surgery, it's easier to do operations that way. Some of them give exaggerated effects to patients as if they're being paralyzed, and that's not a good thing, right? And they do this by actually doing the same thing as myasthenia gravis. Well, not actually doing the same thing. In myasthenia, we destroy them, but NMBs block them. And what's the answer? Just like edrophonium, we increase acetylcholine. The stigmines do that, and they can reverse the effects of the toxicity. Additionally, stigmines, I'd have no space anymore, can also be used not only for the toxicity due to neuromuscular blockers, but also for toxicity due to anticholinergics. Now, this is easier to understand because, again, stigmines are agonists. So it's a natural enemy of cholinergic antagonists. Okay. Now we have organophosphates, and out of the following, it's actually only ecothiopate and isoflurofate which are actual drugs because they are used for glaucoma. Whereas the rest here are not really drugs. For example, malathion and parathion are insecticides, and they are just mentioned because it's telling us, hey, if you have these insecticides, do not ingest them way too much because too much of that can cause cholinergic excess. Speaking of, do you know that these chemicals, sarin, soman, and tabun, are some of the older generation, but actually the most popular nerve gases? And they are nerve gases being used in chemical warfare. And they also cause the same thing, which can be potentially fatal to people. Before I go to this one, which is actually already the discussion of the adverse effects, let me mention also these above, okay? Because we have some drugs that cannot be classified as carbamates or phosphates, or is not in the same vein as edrophonium, but they are all cholinesterase inhibitors, and they all target the same disease or condition, which is the popular dementia, Alzheimer's disease. Probably, this is a complicated thing. There are many studies still going on today, but it has been postulated for a long time already that a contributor to Alzheimer's disease are muscarinic receptors, because as was mentioned here, they do have some role in memory. So what are examples of these drugs? We have rivastigmine, tacrine, galantamine, and donepezil. Actually, you will notice that this is the only stigmine that is segregated from the trio here because it's the only stigmine really recognized to work against this one. Why? Something already that's quite advanced. Okay. Now we go to the toxicity again. How can nerve gases be used in warfare? Why is too much of cholinergic effects right here fatal? Well, let's see. We have the classic mnemonic for cholinergic excess, a decades-old one actually, dumbbells. So essentially, the excess of this, an exaggeration of these would cause dumbbells. D first stands for diarrhea, which is what happens when there's too much gut motility. Urination, more than normal. Meiosis, though I wasn't able to write it here, it's up here. One of the B, there are two Bs. One of the two Bs is bronchoconstriction. I already mentioned a while ago, that's not a good thing because if you cause bronchoconstriction, you're forcing asthma, just like in methaqualone. B for bradycardia or slow heartbeats, because we get that from M2 activation. E for emesis, which is actually a lapse on my part because I wasn't able to remember that emesis is an effect, though it's really minor, so I wasn't able to write it because of that. But yeah, sometimes when you trigger cholinergic receptors in the brain, it can give a feeling like you want to throw up. L for lacrimation or flow of tears. The other L is lethargy. So it's a general effect of overstimulation, I guess. And then S here is sweating. Well, we can actually add another S for salivation. So excessive sweating and excessive salivation. Okay. And imagine probably not all of these at once, but a multitude of these happening to you at the same time. That can potentially be at the least uncomfortable, but at most life-threatening. That's why really cholinergic excess is not a joke, to the point that it was even used in warfare, telling us a reminder that you're not supposed to overdose on these. For example, stigmines or organophosphates, be careful in administering them, because if you give too much doses, it's as if you're really subjecting them to poisonous effects. So this covers the examples, uses, and adverse effects of cholinergic agonists.